Welcome to As a Woman, Fertility, Hormones, and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of FFS-For Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. You are listening to the As a Woman podcast. I'm your host, Dr. Natalie Crawford. Today we are talking about what happens next after an unexpected outcome. I know one of the hardest things about going through fertility treatments or the infertility journey, in my opinion, is when something happens that you just do not expect. I'm a big believer that you can handle anything we throw at you as long as we prepare you for it. So today I'm going to walk you through some of the things I think about and I talk about with my patients when we have an unexpected outcome after a treatment cycle. Before we dive in, if you're listening to this in real time, this is the episode released before the presidential election in 2024. Please go and vote. Voting is what gives you power. It allows you to have a say in our government. And this election, more than ever, women's rights and women's health care, they are on the line. And if you want to learn more about that, I have episodes about IVF and how some of these abortion bans or personhood bills can impact the practice of IVF. I've also just talked about reproductive rights in general and how these restrictions can impact a pregnancy and pregnancy management. Something to make sure that you're educated on and you educate your family members, but more than anything, take the time, show up in line, vote, have your voice heard, strength and power in numbers. We're all counting on each other to get this job done. Every episode, we answer some of your questions. So these questions might be answered in voicemail. They might be answered because you asked them on Instagram or in the newsletter. So very quickly, you will hear some of these questions at the end of the episode, but you can ask them on the voicemail at 657-229-3672. You can ask them on Instagram every Monday at nataliecrawfordmd. Some of those questions will be answered there. Or you can sign up for the weekly newsletter, nataliecrawfordmd.com/newsletter. That newsletter has a ton of information, but we are really working to get extra content to people who are highly interested. Also has codes, things that my friends are doing. I have amazing friends releasing books or having courses, and a lot of them have discounts that you might be interested in. So go ahead and subscribe. Lastly, on YouTube, I have been starting a live Q&A, which is just really fantastic because I so rarely get to interact with you guys live. So subscribe to the YouTube channel, Natalie Crawford MD, and you'll see some of our posts about when the next live Q&A will be coming up. An unexpected outcome can be really tough no matter what. I always say if you think you're running a 5K and it's a marathon, you are woefully unprepared, and that is hard. So when something happens that you didn't even know could happen, it really sets you back, and it starts to play with your mind as you doubt so many things that you thought you knew or what to expect. Can it even happen? Is it worth it? This leads to what are your expectations, number one, to begin with, and making sure that you have some, because the expectation that it's just going to work is probably not realistic. We need to think about more finite markers to know if we are having the expected outcome or not. Let's start with an example from somebody who had an unexpected outcome to see what this might sound or feel like.
Hi, Dr. Natalie. My name's Taylor. I first want to start by thanking you for all the education that you provide and what you're doing for the world of infertility. I've listened to your podcast for quite some time now, and I just appreciate you so much. So just a little bit about my history. I'm 31 years old now. When I was 23, I conceived my son kind of by accident. I was on birth control, but it was a totally normal pregnancy. I delivered at 39 weeks via C-section, had absolutely zero complications. For about the first 5 years of his life, I wasn't on any kind of birth control, but also wasn't trying to conceive at all. I did have an IUD from 2021 to 2023 when my husband and I got married, and we started trying to conceive last July when my IUD got taken out. I got pregnant finally 5 months later, December of 23, but unfortunately it resulted in a miscarriage at 6 weeks, 4 days. And since then we've been unable to conceive. We want 2 more kids. So we started to do some investigating in our fertility and found out that my AMH was 0.68 the first time we tested it, and then the second time we tested it, it was 1. And like I said, I'm 31, so definitely lower than we had hoped. So we decided to go through with IVF since we want 2 more children. Last week I had my first retrieval. I got 12 eggs, but only 2 were M2s and 4 were M1s. Of those 6, 5 were fertilized, but I just found out today that none of them made it to the blastocyst stage, unfortunately. So I'm just curious as to what could have caused them to all stop growing when they all fertilized normally, and what I can do moving forward. Like, is there hope? Can I try another cycle? What can I do to try and make things better? Thank you so much.
And so before we dive into some specifics, I want to just give some general categories. We think about fertility treatments. What are the treatments we have? We have ovulation induction, medications to make you ovulate. We have IUI, an intrauterine insemination, where we take the sperm and we put it into the uterus. We have the combination of both of those, ovulation induction plus an IUI. And we have IVF in a variety of different ways, fresh, frozen transfers, genetic testing, and not. And then the last category is reproductive surgery, things like taking out polyps, fibroids, septums. And so when you go through any of these types of treatment, it's really important to understand what's expected versus what's a marker of success. And sometimes, I hate the word failure, but I'll have people say, oh, I failed that ovulation induction cycle. Failure to me, if we start with this example, means you do not ovulate. So I give you medication because I'm trying to make you ovulate and you do not. To me, that's a failure of that dose. Now, ovulating but not achieving pregnancy is not a failure of the cycle because you're not going to get pregnant in every ovulation induction cycle. And the cycle did what it was expected to do, which was to make you ovulate for somebody who didn't before. Understanding the difference in these two and what the game plan is now and long term is really important. So for example, if you have PCOS, you see your doctor, you get your evaluation, and you're going to do ovulation induction, the odds of it working, meaning getting pregnant per cycle, is never going to be higher than your age-related chance of getting pregnant, number one. So if you are older, you might not have a very high chance. If you're 39 trying ovulation induction, you may have a 5% chance of getting pregnant in that month. Now, that's the expected outcome is response to the medication, confirm ovulation, and then we will see if you get pregnant or not. But not achieving a pregnancy and an ovulation induction cycle at 39 is actually the expected outcome. But I do expect you to respond to it. Now, another way to think about this is if you're not ovulating or if you're over-responding, if the cycle gets canceled, those are more unexpected outcomes or the cycle's not working itself. Similarly, with an IUI, what can happen? Of course, when they're combined, you can have issues with the ovulation induction. I always say you have to ovulate so you can not respond, you can over-respond, and you can ovulate too early. So there's some nuance with making sure you're timing things correctly. From the IUI standpoint, you have to be able to produce that day. You have to have sperm. I've had even donor sperm. One time I had a patient, and she's pregnant now, who had donor sperm sent from the sperm bank. And when we went to go use it, they forgot to fill the tank with liquid nitrogen, and so the sperm is totally thawed. So just like you might have a partner who fails to be able to produce sperm on one day, you similarly, if we're thawing donor sperm from a sperm bank, there's no guarantees in either of those avenues. The IUI could also be really difficult, not be able to get into the uterus, and those would all be unexpected outcomes in that scenario. The rate of getting pregnant from an IUI is never going to be higher than your age-related chance. So when I think about ovulation induction and or an IUI, I'm always thinking about these are things I'm trying to get you back to what your age-related norm should be of your chance of pregnancy per month if you did not have infertility. Never going to get higher. Another thing that falls into that same camp is going to be reproductive surgery. So if you had scar tissue inside the uterus and I can go take it out, now I'm getting you back to that age-related chance. What is an unexpected outcome from surgery? Not being able to complete the surgery, having a complication, having a more prolonged healing period or wait time. Those things can all feel really unexpected. So when we think through these different scenarios, here are some top things I like to think about before going into it that can prepare you. So if it's ovulation induction, what medication are we using? How are we monitoring if I responded to the medication? Are we having an ultrasound? Am I checking a progesterone blood level? Am I following with ovulation tests? What am I doing? What confirms that it worked? Quote unquote, I ovulated. Is there a goal? And this is more specifically if you're having ultrasound monitoring. Is there a certain number of follicles, a certain size you're looking for them to be? That helps you be able to interpret what you are seeing. And then what are you going to do in the scenarios? So what if I don't respond? What's next? Most often it'll be, oh, we'll increase the dose and try again. What happens if I over respond? Most of the time that's going to be, we're going to cancel the cycle and then we're going to start back over. Often when somebody doesn't ovulate, we start thinking about using ovulation induction medication, and if everything else is normal, letting them just have intercourse. I'm a big proponent of completing the fertility evaluation because you don't know what you don't know. And that means semen analysis, make sure the tubes are open. At some point, you might respond to the medication, ovulate beautifully, and still not get pregnant. If that happens, then you get to graduate into unexplained infertility, which I'll cover in a second. When it comes to an IUI, what is expected and what are the unexpecteds? So number one scenario is going to be there's no sperm or partner can't produce. That's going to mess up an IUI. Typically, an IUI does have some minimum sperm requirements so that if you have very, very low sperm counts, you're typically not a good candidate for this anyway. But thinking about, are they looking to see if there's motile sperm present the day of the IUI? If your partner has a problem producing at some point, should you have a backup sample? Should you have frozen sperm available? If you're using donor sperm, I always recommend having a backup vial just because you never know. So ordering more than just that one vial and thinking through some of those scenarios with your team. A few little tips. An IUI is typically easier if your bladder is full. It neutralizes the uterus. So even though that doesn't make the most fun speculum exam, it can make the IUI portion a little bit easier. So think about not emptying your bladder right before the procedure. And when it comes to surgery, surgery is one of those diagnostic therapeutic scenarios. So this one, often we are changing a plan. I had a patient recently who we had a whole plan and we went to do a diagnostic surgery as a part of it. And we found something that totally changed how we're viewing our next steps. That's part of why we do surgery. But understand the nuance and the flexibility there. But still think through, well, what are we expecting? Based on that, what would be the next steps? And good question to ask is, what else could it be? Think through, okay, if it was that, what's the longest I could potentially have to recover or not try? Those just help frame your expectations appropriately. And then when it comes to unexplained infertility and IVF, these are a little bit more complicated. For unexplained infertility, in general, I have a lot of content here, but I like to think about unexplained infertility, egg, sperm, environment. And these are the factors that I'm always thinking about might be playing a role. When it comes to unexplained, it's really tough because you're getting all those tests, quote unquote, normal, and you get this message feeling like everything's fine, we don't know what's going on, but you're still not having success. So obviously something is wrong. It's just not falling into those easy to diagnose categories. When we think about these, what can we do about them? So really we're trying to change egg, change sperm, change environment. 100%, the easiest way to do this is IVF because we're getting more eggs, we're growing them, I'm taking them out of the body, so I'm changing the environment. I can fertilize one sperm into the egg if they're having a hard time with fertilization. I can grow them in the lab in this very nice neutral environment. And I can do genetic testing. I can select the best embryo. I can do a frozen embryo transfer, change the uterine environment before I put the embryo inside. IVF also allows you to see a little bit more about the egg, the sperm quality or functionality, and that does give you some answers. Another time we often will say IVF can be diagnostic also. But the other option before we dive into all the things that can be unexpected with IVF, when it comes to unexplained infertility, a lot of people want to take a lesser aggressive approach. And if you're younger, that's not wrong, but I want you to always think about the big picture and think about what might make sense for you. First line kind of treatment, I always say, is lifestyle changes. Is there anything we can do to change environment to decrease inflammation? Number 2, make sure you really have a complete evaluation. That includes making sure your doctor knows all of your symptoms, your family history. If everybody in your whole family has autoimmune thyroid disease, have you been tested for Hashimoto's? That's not a normal part of a fertility evaluation, but maybe it should be for you. So make sure that you have given that history and presented that good information. Number 3, next step is to say, well, let's just try to put more eggs and sperm together. And this is with the idea that maybe there's some timing issues or maybe there's something subtle going on. And this is what we call ovulation induction plus an IUI, also called controlled ovarian hyperstimulation, with the goal to get more than one egg and to get the sperm closer. I use bad sports analogies, so bear with me. This is like having 2 goals at the end of the field instead of just one, or having one bigger, better goal. And I'm moving my players further down the field. So I am lining up the shot. By no means am I assuring the shot happens. It might not. And if all the players have broken legs or there's water bottles all over the field, they're still going to have difficulty making this happen. But we are just improving the odds that it can. We're taking out other variables. Instead of being 100 yards away, we're 50 yards away. So we are just trying to get those players closer to where they need to be. We're trying to take out some of the debris with that IUI, so get those water bottles off the field. But we're not changing the quality of the players. They're still injured. They are still injured. With unexplained infertility, doing ovulation induction plus an IUI, even if you are young, is not going to get you more than a 10% chance of success per cycle. And that's really important. And if you're 38 and older, studies don't support doing this. It will cost you more money to do this step. You should go on to IVF. Also, people who should consider going on to IVF, in my mind, are people who potentially have anything autoimmune going on, anything that we think could be inflammatory, any endometriosis, things that are environmental. Because in the sports analogy of the IUI, if it's pouring down rain, hailing, the environment's toxic, it still is, even if I have 2 goals and move the players further. The environment is not changed in that circumstance. So if you're doing ovulation induction plus IUI for unexplained infertility, 9 out of 10 times it's not going to work. It's not 0, but it means most of the time it's not. Doesn't mean it's wrong to try, but you have to ask the questions ahead of time. What are my odds of this working? How many cycles of this are we going to do? What is my goal number of follicles? What are signs that we need to move on faster? What are signs that maybe this isn't a good treatment option and we should just skip this and be more aggressive? Last note about this is, even though we want more than one goal, 2 or 3 is ideal, I don't want 5. I don't want 6. The younger you are, the harder it can be to get just enough but not too many. And having canceled cycles for over-response when you've been trying for a long time can be so hard. If we go into IVF, unexpected outcomes, which is what I deal with much more of the time, many people, especially people who are young who go into IVF, are told this is going to work. You'll be 1 cycle and done. And even though that's not wrong, and we wouldn't say it if it wasn't generally true, you'll have people like Taylor who had a really unexpected outcome at a young age, and you heard her questions. Is it even worth it? Should I even do it again? And those are really normal feelings and emotions, and just shows how bad we all are sometimes at preparing people for all the things that can happen. Number 1 is when we talk about the expected outcome and thinking about other things that can happen. I always look at this in a few ways for IVF cycles. First is going to be what got us into this situation. So in this case, secondary infertility, somebody who has a baby in the past with unexpected low ovarian reserve, AMH of 0.68 or 1 are very low numbers for somebody who's 31. They're not zero. We're not out of eggs. But I believe the world is connected. So these two things are probably related. Whatever is causing our low AMH is probably also causing our secondary infertility. Low AMH does not cause secondary infertility, okay? Having fewer eggs, as long as you're still ovulating, does not cause problems with you getting pregnant. But we should always step back and say, is this just what my potential is? I was just born with less eggs. Or is there a reason why both these things are true? And I think that's an important step that sometimes we gloss over. So is there anything in our life? Have we had any new diagnosis, any autoimmune disease in the family? Do we have really painful periods? Like we might have endometriosis. Did we have a really terrible C-section, lose a ton of blood? So when we think through what is causing some of these scenarios, that's step number one. Is there anything that could be causing this? When there's nothing obvious, which is the case for Taylor, then I always say, I'm going to presume it's undiagnosed autoimmune or inflammation something, because something's going on. So I'm going to approach my protocols that way. That's not the true case for everybody, but I think going through that thought exercise is always important. Number 3 is looking at the protocol. So when it comes to IVF outcomes, the job of the protocol is to get you as many mature eggs as possible. I'd love it to be get you as many normal embryos as possible, but truly, if we look at the most finite marker of what the IVF protocol is supposed to do, the expectation is to try to get as many eggs as we can that are mature. So right away, we know we fell off that mark. When we think through egg maturity, you can have over mature eggs. I'm putting that in air quotes. It's not a real term, but I like to think about these degenerated eggs that were there too long. M2s have completed the second stage of meiosis. They're perfect. M1s are immature. They are slightly immature. They haven't gone through that second stage of meiosis. And then you have GVs, which are totally immature, haven't even started meiosis. They got no thought of going through. But what's normal? Normal is based on one, we have age-related norms, but we also have more specific norms based on your antral follicle count and your AMH. So for age 31, I would generally expect somebody to have about 16 to 20 eggs, but with an AMH of 1, I would be expecting closer to 10 to 12. So 12 eggs at egg retrieval, that's good. Your ovaries had what they needed. Sometimes I see somebody only has 4 eggs growing, which that can be really concerning if that's all your ovary has. In this case, we had 12 at retrieval, but only 6 were M1s or M2s. So right off the bat, the protocol did not do its full job. We had more eggs that we did not get to maturity. This doesn't mean always that the protocol selected wrong. There's personalization along the way, and we learn a lot about you when we get your eggs in the lab. So this might say, hey, you need a shorter trigger interval, a longer one, a bigger size, a smaller size. It might mean you need a totally different protocol. In this case, sometimes I see that patients have antagonist cycles because they are young, when maybe a Lupron downregulation might be a better choice based on their egg count. So what was the protocol type? What were the egg sizes? What happened to the other 6? Were they degenerated or GVs? And then the 4 M1s, to me, also highly concerning. When we look at this, I see 2 mature eggs. 2. Now, not every egg is going to be mature. I usually say we expect about 80% of what we get to be mature. But 2 out of 12 is way undershooting it. You can only ICSI, which is taking a sperm and putting it into an egg, eggs that are M2s. So likely we did conventional fertilization, which based on the thought that we've been pregnant twice wouldn't necessarily be wrong. However, when we have unexplained infertility, I'm always trying to control variables I can. This was probably conventional fertilization because since there were M1s that we counted as fertilizing, that can only happen usually if you just leave them all in the dish. Studies support you don't have to do ICSI for unexplained infertility. I'm controlling Subjectively with my patients, I like to do it. I like getting more data. I like knowing we're putting a good looking sperm into the eggs. Also, if we look at this as only 2 mature eggs, because we only had 2 M2s, of the mature eggs, we typically see fertilization of about 75 to 80%. And from those that fertilize, we see about 50% make it to the blastocyst stage. So if I only had 2 mature, getting to 0 blast doesn't feel nearly as concerning as saying I had 12 eggs at retrieval and got none to blast. They are both true statements, but we're looking through a different lens. And part of an unexpected outcome where we under responded or had a longer this or we got something we weren't thinking we would is, do we have something that we can change or a reason why this happened that puts us in a spot to feel more confident it's not going to happen again? So right off the bat, when I have somebody with no blasts, thinking through, I don't love protocols like this when I see this type of outcome. So questions that I would be asking is, what is this protocol? Should we consider changing a protocol? Maybe we should consider ICSI if we didn't do ICSI. That's a different type of fertilization. What happened to the eggs that weren't mature? Were they over or under? Can we say, or did we ovulate early? Do we need to change our trigger parameters? Where did the blasts stop growing? Did they all stop at the 2-cell stage, the 8-cell stage? Were they morulas? Those answers can sometimes help us understand if we think it's more egg-related or sperm-related or both. So I think number one, when I'm looking at can I get a better outcome, when I have a protocol that underperforms for a certain patient, now I can say I'm going to make all of these little nuanced changes. I like to add in human growth hormone sometimes if I got an unexpected outcome. Sometimes we're changing the stem protocol, changing the goal size, changing the trigger parameters, changing the type of fertilization. And so those are all things that we can think about that can really add up. No matter what, we should be stepping back and trying to think about, do we have any signs, symptoms that we have something else going on that's not diagnosed? Have we been tested for those things? How can we decrease inflammation in our lives? How do we say, I'm going to control the factors I can. We're going to stop drinking. We're going to eat more plants. We're going to get good sleep. We're going to go on nightly walks. Are there any supplements we can take to decrease inflammation? Not every supplement is right for everybody, so that's not the answer. I will often see patients come in with 20 supplements, and that's never what I want. But really thinking about why might it help you, what might you be lacking, and what can this bring to the table? There are times I tell patients, there's nothing I would change about this. I would do this again. Getting to a blast is the first hurdle when it comes to IVF. But really, I say the first hurdle is getting as many mature eggs as you can, because you're putting that number through that equation. Once you get to blast, if you're doing genetic testing, you're only going to have a certain percentage normal based on your age. So another time I see patients for unexpected outcome is getting more abnormal embryos than we would have thought for your age. And then lining us up for transfer, and having transfers fail or linings not respond can happen on the transfer end. Most people need more than one embryo transfer to get to a baby. Meaning if we're hoping to save up embryos for the future because we want 2 more kids, it can feel so daunting to go through one IVF cycle and have nothing to show for it. However, we learn a lot about our body. We already knew something was going on. Hopefully now we're in a position, because of this unexpected outcome, to be thinking through and asking the questions we need to have a better outcome next. And ultimately, that's part of my goal, is to help empower you to take charge of this fertility journey more, understanding what questions to ask, understanding what to expect, and hopefully making the burden of this process a little bit easier. Unexpected outcomes are always tough. Always, always. I never want you to feel like you're a failure, because you're not. But infertility does not discriminate. It is unpredictable. It always is a marathon, and knowing that you're learning about your body as you go and having the ability to make those dynamic decisions is so important. All right, friends, I'm going to answer a few of your fertility questions. Again, these questions can be asked on voicemail, the newsletter, or on Instagram at nataliecrawfordmd every Monday. How does your doctor decide how many days of estrogen you should have before your frozen embryo transfer? So there's two main treatment cycles for a frozen embryo transfer. There is a natural or a modified natural, where you're ovulating or you're getting medication to ovulate, which is going to grow that egg, and that egg is going to make estrogen. There's also a controlled or medicated cycle where you're taking estrogen, and sometime with other suppressants like Lupron. These two cycles have their pros and cons, and this cycle is talking about a controlled or medicated cycle where you're taking estrogen. Big picture, we're trying to mimic what your body does naturally, which is approximately 2 weeks of estrogen, unopposed, meaning without progesterone, before your body starts making that progesterone. However, when you maybe have a thin lining or your prior cycle results, we may want to give you more or less. So we might give you more days, we might give you fewer days, we might have multiple routes of estrogen. There's pill, patch, vaginal. So there's a lot of different ways we can do this. Generally, you'll see about 2 weeks, typically not longer than 3 weeks. And that is to just try to get that lining to that most organized, thickest place that we can before you ovulate or make any natural progesterone. Why did I not retrieve as many follicles as I was expected to? For one, what we are measuring is typically anything that we see. So there are going to be small follicles we might see on ultrasound that we know are not going to have a mature egg, but we are measuring them anyway because that might help our decision making the next time. So one of the causes is that we measured follicles we knew were not truly in the running. And I always try to preface this to my patients saying, I'm measuring 20, but based on the normal range of maturity, I'm expecting 16 or 17 of these to be mature. Second from there is going to be, sometimes you could start ovulating early. So if you start ovulating early, did you lose some follicles? Did your ovulation blocker not last as long? Did some start to collapse? Were eggs degenerated and they didn't count them? Or the various stages of maturity like we saw in Taylor's case? So I think it's just important for you to think through what was expected, ask at your follow-up visit, why did you get what you got? What happened to the others? Were they too small? We didn't expect them. Were they too big? Did we ovulate early? And what changes can we make based on this information? So how long does it take to increase sperm count motility, and are there any tips? Remember that the sperm life cycle is about 90 days. So that means 90 days from now, we can see an entirely new group of sperm in the ejaculate. But sperm are being made every second, every minute, every day. So changes now can be seen even in 30, 60 days. All the sperm won't be changed over, but you can start to see some of that improvement. However, if you're trying to go from really low back up to normal, it might take you even longer. It might take closer to 6 months. So it really depends on what the counts are and what you're doing about it. Things that you can do include lifestyle changes, removing toxic behavior, and increasing anti-inflammatory behavior. But there's also some medications, so things like Clomid or HCG can help the brain stimulate more testosterone and sperm production. Remember, we do not want you to be taking testosterone. That does not help make more sperm. In fact, it is more like male birth control, and it decreases your sperm production to 0. And trying to improve sperm counts after testosterone use, it's not always reversible. So this is where I always say, have a real honest discussion about your behavior and what you can and can't change, and think through what you can do differently. And typically we repeat a semen analysis in 3 months to see if we've made that change. Well, I hope that helped answer some of your questions. As always, you can ask them on Instagram on Monday at nataliecrawfordmd. You can also ask them in the weekly newsletter at nataliecrawfordmd.com. Or you can call and leave your own voicemail, 657-229-3672. Thank you, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd, and check out the YouTube channel, Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.